Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. Great to see you all again. And for those of you who have watched our show before, you know that each week we have a special guest from a different healthcare discipline who works with our team of specialists to give you, the patient, the best possible care necessary. Very often in a trauma clinic such as ours, with people who have slip and falls, car accidents, and other types of injuries, it's sometimes difficult, or it creates a little bit of a task to form an accurate diagnosis when many different things are possible. Such as a person comes in with a whiplash injury. They have pain radiating down their neck, down into their arms, down into their hands, and numbness and tingling in their arms or hands. We sometimes have to go through a multitude of tests to find out if these hand symptoms are due to a problem in the neck, a problem in the elbow, or a problem elsewhere which might be causing that symptom. And after going through testing, if we have determined that the problem is in the arm or in the hand, we then send the patient out to a specialist who specializes in those areas. Today, it is my great honor and pleasure to have Dr. Neil Hochwald join us today. Hi, Dr. Hochwald. Thanks for joining us.
Thanks for having me.
And so, Dr. Hochwald, you are a hand and arm specialist, correct?
Yes, I am.
Great. And let's talk a little bit about your training, where you go to school, how many years it was, what was involved?
Sure. So training involves 4 years of undergraduate studies, which I finished at New York University, and then on to 4 years of medical school, which I also finished at New York University. And then after that, I chose to do an orthopedic residency, which is a 5-year training program that trains you in all disciplines of orthopedics in the whole body. Any bone problems, tendon problems, some nerve and soft tissue problems, but then I chose after that to do an extra year of a hand fellowship training, which focuses on the upper extremity or the hand, the arm, including up to the shoulder. And in that year of fellowship training, I learned as much as possible about the hand and the arm to try to specialize in that field. And that's when I finished at Hospital for Joint Diseases. After that, I went on to practice in Huntington, Long Island.
Mm-hmm. Excellent. Okay. Wow, that's a lot. It's a lot of schooling. A lot of training.
Yes.
What's like the most common condition that you treat in your office?
Probably nerve impingement problems such as carpal tunnel syndrome, a tendon problem such as trigger fingers, arthritic problems of the hand, and unfortunately there's lots of injuries to the hand because the hand is used as an exploring tool for children, adults, and there's lots of fingertip injuries and trauma that is associated. Right.
So we're going to start with the first topic, carpal tunnel syndrome.
Yes.
And I mean, I know what it is, but I want you now to try to explain to the audience what that is. Can we have the first slide, please?
So carpal tunnel syndrome is a pinched nerve, and the median nerve, which is the nerve that travels down the middle of the forearm into the hand, is pinched at the level of the wrist. The slide shows a picture of where there's a ligament called the transverse carpal ligament that is one of the borders of the tunnel that the nerve goes through. And over time, for various causes, the nerve gets pinched under this ligament, and the ligament is a stout structure that anchors some of the wrist bones. So the tunnel is a small cross-sectional area where the nerve goes through, as well as 9 tendons that flex our fingers. Right. Inflammation happens in that tunnel, wear and tear, arthritis impinges on the nerve, and the nerve stops working over time slowly.
And thank you for the slide. Okay, so the way that you treat that is, I believe you cut that retinaculum tendon to free up the nerve, correct?
Yes, as a hand surgeon, most of my practice is actually not surgery. It's actually trying to treat problems with conservative means when possible. So yes, surgery is needed sometimes, but for milder forms of this condition, where there's inflammation, there's numbness and tingling, the hand is falling asleep, the most common time that patients with carpal tunnel syndrome have symptoms is at night. They wake up from the sleep with their hand numb and they have to shake their arm out to wake it up, to get the pins and needles out of the hand. The next most common time is while driving and when using the hands to manipulate small objects or to hold the book. A lot of people start feeling symptoms of numbness and tingling in the hand falling asleep.
Right. Have you seen that been caused by like a person in a motor vehicle accident where they rear-ended it or have a front impact and they're holding on to the wheel?
Yes, I have.
Okay.
There are lots of causes of which a lot of people fall into a category that we don't know for sure, but trauma, hand trauma is definitely one of the causes. There are people that develop carpal tunnel that have numbness and tingling and the hand falling asleep, and it seems to be more common in females at around age 40 that they tend to develop symptoms, and in a lot of people with no medical problems. So it's thought to be that it could be inheritance. There could be a small tunnel that the nerve goes through, and sometimes so there are some anatomic factors. Anything that causes swelling around the nerve, so pregnancy, impinges on the space, arthritis, as I said, anything that impinges on the area that the nerve goes through.
Very interesting. The next thing you told me you treat a lot of is a condition called trigger finger.
Yes.
Can you kind of explain what that is?
Yes, so that's a tendinitis. So just like carpal tunnel is a tunnel problem where the nerve goes through and the nerve is being pinched and losing its circulation, and you get pins and needles. With tendinitis, it's another tunnel problem where the tendons are going through a tunnel that is narrowed over time from the friction going on, and the tendon gets caught in the tunnel. And these are the tendons that flex the fingers, or the flexor tendons.
Now, can we see slide 02, please?
So what happens is that the enlarged part of the tendon, the swollen part of the tendon, gets caught up in the tunnel system. And we have a video that's going to come up showing the trigger finger.
Let's play the video, please.
Do it again. Squeeze hard. Great. One more time. So the video showed a ring finger that is getting stuck. The tendon that slides back and forth enters a tunnel system as it goes into the palm. And the narrowing of the tunnel is impinging on the tendon, and the tendon gets stuck. And when you flex your fingers down, the large part of the tendon gets stuck as it tries to go back up to this tunnel, and it snaps open. And that's what's called a trigger finger. Interesting.
Can we see video 02B, please?
Ridiculous, right? It's like road testing to you, right?
Excuse me?
What's the matter?
I usually take guns on the page.
Oh, okay. Yeah, if you have to come in for another one, if you're like this, you gotta
Okay,
take...
okay, everybody out.
Everybody out.
You moved your hand.
Peter,
Yeah.
make a tight fist for me. All the way, good. Open up your hands now. Open all your fingers. I want you to do it again, please. Right, open up your hand again all the way.
Good job.
Do it again. And open out all the way now.
And open up.
Right, all the way back. Good. Make a fist one more time. Now open up your hand again all the way. Beautiful.
So the video that was just played showed that same hand the ring finger having a surgical release of the tunnel system. So the start of the tunnel system is open for a short distance in the palm, and it's done while the patient's awake. It's a surgical procedure where we make an incision, obviously, and it is a 10-minute procedure where the tunnel is snipped open just to make more room for the tendon. And you can see right away the results of it, so the finger's not locking or getting stuck.
And so is that patient's awake while you're doing that?
That patient's awake.
And then after you get done, he's actually able to flex it, and there's nothing getting caught anymore?
Immediately.
Wow, that's pretty cool, man. Now, besides surgery for carpal tunnel and for trigger finger, what other things do you do in your office to help those patients, let's say before surgery?
Yes. For trigger fingers that we just saw, we try a cortisone injection, sometimes up to 2. There are patients that do respond to cortisone, and the cortisone gets inflammation down, and there are about 60 to 70% of patients that have trigger fingers that do respond to cortisone injections and don't end up needing surgery.
Wow, that's great. That's great. Another condition that we talked about, can you please put up picture number 03, please? Is a condition called Dupuytren's contracture.
Yes.
Can you explain what that is?
Dupuytren's contracture is a thickening of tissue that anchors the skin in the palm, and it grows as we age. There's probably an inheritance factor that patients seem to run in families, not often the direct father, but it could be a distant uncle. And it's enlargement of the tissue that anchors the skin, causing the skin to get thickened and then contract, and it goes between the tendons and the skin, pulling the finger into a flexed position slowly over time.
Wow. Let's see the video on how you surgically help that patient.
You feel like you're
Well, yeah. You okay?
I heard that just then.
You did, didn't you? Make a fist for me. Open up your hand all the way.
Wow.
Do it again. Open it up all the way. Very nice. So there's a little, just right where you would think it would happen. But just partial thickness on that. And I'm just going to work a little bit.
Is that the notatory?
Yeah, it's more of a notch. It really has a notatory ligament.
So, Doc, explain what we just saw in that video, what you were actually doing to help that patient.
Sure. That procedure, which has been performed more commonly over the last several years, is a minimally invasive technique called a needle aponeurotomy. And what's done is that a small caliber needle is injected with a little Novocaine first to numb the skin, and the needle is used to actually basically saw through this thickened cord and fibrous tissue, because often there's a thick band that runs up the finger that if you actually multiply puncture with this needle, it's like a rope that you weaken, and it gradually frays and then loses its strength. And by manipulating the finger straight, you could see that the finger straightened out right away. And that's, again, a procedure done under a local anesthesia where the finger is right away manipulated into a full straight position often, and they can start flexing and moving right away. The traditional treatment for that condition had been surgery for many years, which is more invasive, removing all that diseased tissue or as much as possible. You can't really cure this condition because it's on a cellular level and it grows, and it's hard to get all the cells out. So there is an incidence of it coming back and scar tissue forming after surgery.
Right.
And surgery is much more involved and much harder for the patient because it's swelling and pain that happens and difficulty getting motion back.
Let me explain something to you, the audience, just so we're clear on, where our show is coming from and, why Dr. Hochwald is here today, as well as many other surgeons and health care practitioners we've had in the past. In our clinics in Melville, Hicksville, and Ronkonkoma, our multidiscipline team is geared to always try conservative means first. A patient may go through chiropractic, they may go through physical therapy, they may go through acupuncture, they may go through massage, they might go through physical therapy, stretching, all kinds of different modalities conservatively first. But sometimes, even with all that conservative treatment, the patient is still left with a lot of pain and a lot of disability. And that's when, thank God, we have practitioners like Dr. Hochwald that we can then call up and say, look, we tried everything. And then he may not jump into surgery right away. He may try, like he said, some cortisone shots, right, or some other treatment. And surgery is always your last thing that you go for, right?
I mean, for instance, with carpal tunnel, there are many patients that are treated conservatively if they have a flare-up of numbness and tingling, that it can settle down, and that sometimes you try a wrist brace to hold the wrist still, because when the wrist is flexed or extended, the pressure in the nerve goes up so that the nerve is irritated more when it's not straight. So when you put a wrist brace on and keep the wrist straight, it lowers the pressure around the nerve, and patients can feel better with it. It's mostly worn at night, but people do get flare-up of these conditions, and then it calms down. But the people that need the surgery are the ones that have the numbness and tingling and the hand falling asleep, and it's getting progressive, where it's not going away anymore, where the numbness is there all the time, where the hand is getting weak because that same nerve gives power to some of the thumb muscles. And if you wait too long without treating it and make more room for the nerve surgically, the nerve will deteriorate further and you'll lose more hand function. So those are the patients that need surgery, the ones that don't respond to conservative care and have progressive symptoms.
Right, and neurologically, you see their muscles atrophying in their hands. They may have an EMG or NCV nerve conduction test done, and you see there's very little nerve flow into that hand. I guess there comes a point where you have to do it, or they're just going to get more and more neurological loss, right? If they don't do something and relieve that nerve pressure.
Yes, and those patients are the ones that you would, potentially their hand would be more compromised, because once the nerve starts to deteriorate, nerves don't regenerate like other tissues. You often don't get that back. So those are the ones you want to be more aggressive with.
Well, one of the things I just learned today before we started the show, which I thought was pretty cool, is that when most surgeons, I believe, let's say when an orthopedist goes into an ER for an emergency and he's setting a bone, let's say a fractured femur, that if somebody has a ruptured blood vessel or ruptured nerves, they bring other specialists in, vascular surgeons, neurosurgeons, to help the ortho, to treat the patient. And I just learned today that in your practice as a hand surgeon, you're able to work on all those things, correct?
Correct,
You can work on the injured nerves, the injured tendons, the injured blood vessels. That's part of your training as a hand surgeon.
It is. Most hand surgeons are comfortable treating all parts of the hand that can be injured. And that's one of the reasons why I chose hand surgery, because it's, although I have an orthopedic background, there's a little bit more finesse as far as on a detailed level of treating structures that are injured. And because you get to do some vascular type surgery, fixing blood vessels, you get to do some plastic type surgery where you actually do skin grafts and do flaps to cover soft tissue defects that happen from saw injuries and multiple other injuries. And because you fix bone, tendons, it's really multiple kind of overlapping disciplines that you're taking care of, and that makes it more interesting.
And you have your own operating room right in your office, correct?
Yes,
and that's in Huntington, right? East Main Street?
Yes, it is, yes.
The Huntington Hand Center.
Yes.
I know, because I've been there. You operated on both of my wrists.
That's right.
You did a great job. Thank you.
You're welcome.
Yeah. And so I would imagine, and I've heard this before from other surgeons, that if a patient has an option to do a surgery, let's say on an arm or on a hand, they're better off going to an ambulatory surgical center or a private in-office surgical suite than to a hospital where there's a lot of sick people and more chance of infection. Is that true?
That is true. I mean, the chance of infection would be lower in a facility such as ours, where we have, for the most part, relatively healthy patients with injuries and other non-life-threatening problems that come in and need elective surgery done. And although some of them are trauma patients that need their fracture repaired acutely, a lot of patients are on the healthier side. And because there's that less mix of sick patients, the chance of infection is lower in an ambulatory surgery center. We have a single kind of specialty that we do in orthopedics in our facility that we are all trained to do the same thing. So we all are focused on the hand and the arm, and we do the same procedures over and over. So we specialize it, and we get good at it by repeating it.
And you're not just, you just don't work on the hand. I mean, you work on the elbow and the shoulder also, correct?
Yes. I mean,
anything with the shoulder down?
Right. As the song goes, it is all connected. So,
Yes.
so we start with the hand, but the same nerves that go into the hand that give feeling and function to the muscles in the hand also travel down the arm.
Right.
And those nerves could be injured and pinched and in other areas. So we do often work around the elbow to fix fractures and also to release nerve compressions around the elbow as well.
I'll never forget the day my son, who practices with me, who's now 31 years old, when he was younger, he was in a Taekwondo tournament, and he did a spin and he tried to block a kick,
Yes.
and he said his arm hurt, went into the corner, Dad, my arm hurts. I thought, man, get back in there, it's probably just bruised.
Right.
And hold that arm behind your back and use your legs. Bad decision, because by the time I brought him down to the ER, he had broken his arm, and you did a great job surgically, pinning it in plates or whatever you did, and he's back to full 100% right now.
Thank you. Yeah.
I have a question for you. So, are there ever any cases that you can't do in your surgical suite and must do in a hospital?
Sure. We do take care of amputations and in finger reattachments. Those can be quite involved, mostly because they require specialized equipment and resources and then monitoring afterward. Mm-hmm. So patients that have these delicate microsurgical procedures, that need these small blood vessels repaired with strands of suture that are smaller than our hair under a microscope,
wow,
have a precarious situation where the blood vessels sometimes remain open, sometimes they don't, depending on lots of factors like the patient's health and their blood flow, their blood pressure. And those patients need to be monitored, and therefore they need to stay in the hospital for a few days to be evaluated. So that would be one example.
If they have like cardiac risks or anything like that, you want to make sure you got the cardiologist right there in case something happens, right?
Yes. I mean, we also are patients that are routine for an ambulatory basis that can come in and go home the same day are appropriate for a facility. But sicker patients that have cardiac risks that need to be monitored and other medical conditions are safer in a facility that has that ability at the same time.
Right. So are you're affiliated with, I know, Huntington Hospital, right?
Yes.
What other hospitals?
Also other North Shore hospitals such as Plainview and Syosset Hospital. Most of our work is at Huntington Hospital. I have two partners, and we alternate taking call and responsibility.
Get those calls in the middle of the night, right?
There are some calls there in the middle of the night, unfortunately. But it happens sometimes. We also work at some Catholic health system hospitals, such as Good Samaritan and St. Catherine of Siena, and I also go to Long Island Jewish, and I'm part of a team with the pediatric orthopedist that works in a clinic on children.
Interesting. Would you tell the audience how they can get in touch with you if they have any questions? Exactly where your office is located, if you have an email with which they can ask questions and respond to.
Sure.
Just let them know.
Sure. My office location is at 166 East Main Street in Huntington. We do have other offices that we see patients also in Bayshore and Plainview. And our main phone number is 631-427-4263. And we also have a website that is Long Island handtoshouldercenter.com. And those are all ways, and if there's any questions, certainly feel free to reach out.
On our next show, we're going to get more into like trauma, like fractures, surgical fractures, arthritic conditions, things like that. But before we wrap this show up, are there pediatric hand surgeons, or do you take care of little babies from the day they're born till people that are geriatric?
There are a few centers around the country that might specialize only in doing pediatric hand surgery, but those are just a few, and they're very big children's hospitals. Mm-hmm. But most hand surgeons do pediatrics and are trained in doing both traumatic conditions in children as well as congenital conditions in children, which I think we'll talk about a little bit more.
Right. I would assume that when anybody gets operated on in your center, they have to get medical clearance, correct, or from their primary care doctor?
Yes, if medical condition warrants it, but there are young patients that we do these surgeries under a local with sedation or nerve blocks to numb the arm. That is very low stress to the patients, and a lot of the patients won't need testing done necessarily.
Very interesting. Well, I'd like to thank you very much for being on the show. It was very, very informative.
Thank you.
And we got a lot more to cover in the next show.
Yes.
But thanks once again.
Thank you.
For those of you watching us on Madhouse TV, we'll be right back. And for those of you watching us on Cablevision, we'll see you next time. And just remember one thing. If what you're looking for is real wealth, join us next time on The Bridge to Health. If you're watching us on Madhouse TV, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again, welcome back to the Bridge to Health. And today we're going to do part B of our show with Dr. Neil Hochwald, hand surgeon. Hi, Dr. Hochwald, welcome back.
Thanks for having me.
And the last time we were here, we spoke about some of the more common things you do in your office, but now we're going to talk about a very traumatic topic, trauma.
Okay.
It must be, I would imagine, very difficult, maybe in the beginning years of practice, I don't know about now, maybe you're more used to it, to see some of these terrible accidents and the pain and the suffering that these people are going through. But I have to, tip my hat to you that, you're a fantastic surgeon for trauma and do a great job. I don't know how you do it, but you do a great job. The first thing we're going to talk about today are fractures and how you deal with those. Can we see slide 05, please? And maybe you could describe to us what we're looking at right here.
Yes, this is a finger that has a fracture at the joint. There's a separation down at the joint, and anytime that the joint is involved with the fracture, you want that to heal as best as possible because that's a gliding surface for the joint. And there are different ways that we fix these, but a lot of them don't need surgery if they're not displaced or out of position and will cause a functional problem. But this can cause a functional problem due to the fact that the gliding surface is involved. So this will often require surgical repair.
Okay. Can we see slide number 6, please?
So this would be one technique to fix the fracture where we open the finger and physically push the bone back in position and put pins in to hold the joint in position. And in the hand, stiffness is very common. So we have lots of structures that go through a small space, and tendons that flex and extend the finger as well as the bone and the soft tissues can get scarred down in scar tissue. So we often have to think about not only fixing the break but how to handle the soft tissues around it so that the patient can not get too stiff and get optimal function and start moving sooner rather than later.
Now what are those? Are those pins that are in there?
Those are pins, and in this case the pins are left outside the skin that's wrapped up by a cast that is over that area, and the pins stay in for about 4 weeks, and they get removed in the office after there's enough healings and the patient starts to do hand therapy. And hand therapy is very important, is part of integral part of the treatment for these fractures to get moving again.
Right. Okay, can we see the next slide, please?
So this is a side view of a forearm that has lots of bone fragments from a radius fracture, and there's pins already that have been put in the bone by an orthopedic surgeon, and the orthopedic surgeon sent this patient to us for our expertise due to the nature of the injury, where there was many bone fragments, or what's called a comminution, that is hard to put together, and we have a plate and screw system that we use often to fix fractures like this of the radius bone, which I think is shown on the next few slides.
Yeah, can we see the next slide, please?
So this is just another frontal view of that same fracture, showing all the bone fragments where it's darker and whiter that are seen there. And then I believe the next few slides show how we handle that.
Yeah, next slide.
And there's a plate that's put in where most of the bone fragments are pushed in position. We actually try to keep most of the bone fragments without removing them because they have soft tissue and they provide bony support and they help with the healing process. Otherwise you have gaps in the bone and have trouble healing. So this plate and screws bridges across that area and gives it support, allows us to remove that external pins that are there and have the patient start moving sooner rather than later with the fracture healing in an excellent position.
Okay, thank you for the slide. So, question I have for you is, do those bones ever not heal with those pins and plates? Do you have to go back in again? Are there stimulators or things that increase the bone healing?
Right.
Supplements and anything like that, which
Right.
helps things
Right.
heal.
So the issue for a lot of these fractures is getting the bone to heal in the correct position. That's what we want to do, to have it heal as close as possible to where it should be. Now, it doesn't always need to be perfect to get a reasonable outcome for a lot of these fractures. So a lot of fractures are treated without surgery. But a case like that, where the bone is so fragmented, it's going to collapse out of position because there's no, it's like having a scaffolding with no support. It's going to collapse back down, and the alignment will be lost, and you'll have pain and arthritis and loss of motion from that. So the fractures that have, most fractures treated non-surgically will heal, most, not certain wrist bones often, like the scaphoid bone, or that has trouble healing at times on its own.
Mm-hmm.
But the ones that have surgery on them, because you actually disturb some of the blood supply, you have to get in a good position and stable, because they have more trouble healing unless you really do a good job to fix it in position. And occasionally we use other sources like extra bone, either synthetic or from patients, to put in the area to fill in the gaps, and other bone stimulators, which are ultrasound driven devices that externally help stimulate bone growth and have shown some promise and help to heal these problem fractures.
Gotcha. There's an old saying out there, and I want to know what you think about it, is that once you break a bone, it heals as good as new, or sometimes better than new, where if you, let's say it's a long bone, let's say it's a humerus, let's say it's a femur, and the person has a subsequent trauma, that area that was fractured before, because all the callus and calcium, everything that forms around it, is sometimes stronger than the rest of the bone. Is that correct or not?
I don't think it's really known for sure, because that would be a difficult study to do, because you'd have to take people with healing bones and then re-break it again and see what the force was to, but it certainly gets at least as strong as it was before. The reason that it's thought maybe it's more strong, because sometimes the extra bone that forms around it is a big lump of thickened tissue, so it looks like it's sturdier, but it's probably a similar strength as before.
Okay. Can we see the next slide, please? And Dr. Hockwell, can you tell us what we're looking at here?
So this is a little bit different. This is a patient with gout. I think the slide before that showed another fracture of a humerus bone. But this is a patient that has another type of problem that we see. This is a problem that I need medical doctors to help treat this condition, but in those patients that have a problem called gout, they have extra uric acid that builds up in their blood. And the uric acid sometimes is deposited in the soft tissues and in the joints around the body. And this is a condition that, unless it's treated with medicines initially, sometimes surgical debridement is needed of these accumulations of gouty tophi, it's called.
Right. All right, thank you for the slide. I just want to back up a little bit, back into trauma again for a minute. Besides fractures, there's other types of trauma you take care of. You take care of deep cuts and lacerations from accidents in the arms and hand. And if you see that, you're able to repair the tendons, any vascular structures. So if somebody is just really mangled, I assume I know some people come to you where they got half their fingers chopped off, you know, split in half from tools or saws or whatever. You take care of all that, right?
Yes, and the worse the injury, obviously the worse prognosis as far as the function afterward, but the common injury is a table saw injury that someone drives it through their hand or finger, and the jagged nature of that saw blade is not a clean cut, and it will often shred structures and make it very difficult to fix. So there are a lot of patients with table saw injuries that will need extensive surgery done, or the part that's injured may not be repairable the way it was because of the amount of soft tissue and bone damage that happens.
Right, gotcha. Let's talk about rotator cuff. You do rotator cuff surgeries too?
Yes, I do.
In your office?
We do, absolutely.
Wow, arthroscopically, right?
Arthroscopically.
And talk to me a little bit about, even though I know, but I want the audience to know, what is an arthroscopic procedure?
Sure. Well, arthroscopic is using small instruments to visualize inside a joint. and there's small openings that are made with a camera that's a few millimeters in size that's put into a joint with other small openings that are placed into the joint to use instruments to help pass sutures and other devices to help shave away bone spurs. So it's a combination of having a few small openings to visualize a joint, to work on a joint, to clean it out, or do an arthroscopic repair of structures that might need to be either sutured or stabilized somehow.
So if somebody has like calcium deposits or degeneration and stuff, you can go in there and just clean it up sometimes, right?
Yes, of course, depending on the nature of the degeneration, but yes, a calcium deposit is a common one in the shoulder that you would have to go in if it's remaining painful for a patient to clean out the calcium deposit, and that can be done arthroscopically often.
You take care of things like tennis elbow and golfer's elbow, you know, in the those type. And how do you treat those?
Yes. Well, those are common conditions, usually in patients that are around age 40, when the body starts to deteriorate a little bit and doesn't heal problems the way it used to. And often it's from some sort of either repetitive or overuse where the tendon attachments around the elbow that go down the forearm get inflamed. So tennis elbow is more pain on the outside of the elbow, golfer's elbow is more on the inside, and in the outside, or what's called lateral epicondylitis, it's often aggravated by people that do resisted a lot of wrist extension or squeezing, where the muscles in the forearm that attach constantly pull on that point on the bone, and that becomes inflamed. So first step is to try to instruct patients on how to try to avoid the heavier manipulation or squeezing, if possible, that tends to bring on this condition. So stretching is often helpful, trying to work on stretching the wrist back and forth to loosen. People have a lot of tight muscles, and sometimes even organized therapy to help them do stretching and gradual strengthening exercises with some isometric resistive exercises can be helpful. But ultrasound therapy can help sometimes, heat the tissues and be helpful. Cortisone injections, just mentioning a lot of things because there's often not one thing that will make them better. So
yeah, we do all those in all of our centers, you know, in our rehab, with our rehab physical therapists. But let's say all that doesn't work. Is there surgery for that?
Yes, there is.
And what's the surgery for that?
So what is done is that the tendon attachment, which is degenerative, is basically removed section of the degenerative tendon so that it stimulates a healing response, and then the more normal appearing tendon is reattached loosely. Really? So you're releasing the tight tendon that is degenerated and actually trying to clean up the area, stimulate some bleeding by actually sometimes smoothing out the bone attachment and then reattaching the tendon, and it can be quite helpful.
Interesting. Very interesting. Okay, so now I want to get back to what we just started before.
Sure.
We saw a little bit about a condition called gout and gouty arthritis.
Yes.
What other types of arthritis do you take care of in your office as a hand surgeon?
So one of the most common things that we see is osteoarthritis, and that's the arthritis that we get as we age. And there are patients that seem to be prone to it. Again, there's probably an inheritance that they get it from their parents and grandparents. And the most common location is at the base of the thumb and at the end joints of the fingers. Those are the joints that probably get the most stress in our hands, and when we grab things, are the first impact that the hand has, and pressure builds up, and the joint deteriorates over time is what we think happens, and the same for the thumb. The thumb is prone right at the base of the thumb to get arthritis, and that's a painful area that happens often in patients starting around age 40.
So besides the rehab that we do in our centers, you do in yours, physical therapy, occupational therapy, your injection therapy, again, is there surgery for very degenerated joints?
Yes, there is.
And what do you do for those?
So
what's the procedure?
Right. If as you mentioned, Tom, that the either therapy or a brace doesn't help, often a brace can help calm things down that you wear that goes up the thumb that people can wear when the pain flares up. But a lot of people over time, they can't use their hands the way they want. The brace doesn't help anymore. Surgery, especially for the base of the thumb, can be quite helpful. And what's done is that the base of the thumb, what's called the metacarpal bone, rubs on one of the wrist bones called the trapezium, and that either part or that whole bone is removed to open the space so that the rubbing doesn't happen anymore. And what happens after that depends on what you believe in. Either you put a pin in and a cast on for a while to allow the body to form scar tissue to stabilize that thumb base, or you take a tendon or tendons from the forearm and pull it up and actually weave it in a fashion at the base of the thumb to anchor it in position to serve as a what's called a suspension of the thumb, because if you're moving the bony support, we think sometimes it needs soft tissue support. And then interposing part of the tendon to serve as like a cushion in the area.
And after you do that procedure, do they generally lose function or gain function?
Well, we do it hopefully to gain function.
Okay.
And
So I don't know if you did it just to relieve pain or
Right,
to also
right.
gain function.
Well, if you get pain relief, that is the best function that people can get sometimes right away, because most people get this surgery done for pain.
Right.
And once you have pain relief, that's a win right there. But function-wise, as far as mobility, is very good. They can move their thumb. Their strength to pinch things and grab things, no one can make them like they're 20 and 30 years old anymore. But the fact that their pain is better and they can put pressure on it,
they can do more
they
things.
can do more things with
Right.
it, and it's right away very helpful. It's a process that the body takes a while to get used to, because we're doing obviously a big procedure to it, but the casting is needed for a while and therapy, but by 3 months they can do many things with their hands.
All right, now we're going to go through a bunch of slides, and we're going to go into other things that you do in your practice other than trauma, carpal tunnel. So can we see the next slide, please? And let's talk about what we're looking at here.
So this is the patient that was shown earlier that has the gout, and that was the swelling on the side of the wrist. And this is the wrist opened up, removing some of this tissue that is this white, chalky-like material, which is the uric acid.
Uric acid, yeah.
And in those patients that have these deposits, we can sometimes clean it out. And again, this is not just a surgical problem, it's a medical problem where they need to be treated with medicines to help lower their uric acid, or dietary restrictions to try to limit the uric acid.
Right, get to the cause.
The cause of it.
That's the end result.
This is the end if nothing else is working.
Right.
Yeah.
Next slide, please. What is that we're looking at?
So this is a side view of the hand that shows another common condition, or conditions that hand surgeons treat, and that's masses in the hand, bumps. And this is a young gentleman that had this mass that was growing that was thought to be a ganglion cyst, which is the most common cyst that we see in the hand. And that's a fluid-filled cyst that comes from a joint or a tendon as an area of inflammation that arises from that joint. But
And then you take the book and smash it and it gets better, right? The old,
that was the old treatment.
the old wives' tale.
The Bible.
Not a good idea, right?
Right, not a good idea, no.
Because it might be this, right?
Right, because so this grew for about 3 years, and initial doctors that saw it thought it was a cyst, which sometimes that's the most common, it is a common location for one, but this continued to grow. And there are many other growths that can happen in the hand, and the next picture will show a picture of the hand
slide,
open
please.
up. So it doesn't project as well perhaps, but this is a kind of a fatty growth, and there's other growths that can happen, like what's called a giant cell tumor that can grow. And besides ganglion cysts, there are many other bumps that we see in the hand. The overwhelming majority are not cancer,
Right.
so a lot of them are treated conservatively, or sometimes if they're fluid-filled like these cysts, we put needles in to puncture them.
Right.
A lot of them don't need surgery for them. Only the ones that are painful or growing that we don't know what they are
Right.
need to be removed.
So again, we may have a patient come into our office with, as doctors of chiropractic, we're not just manipulating bones, we're considered primary portals of entry. So we'll do a full exam, full consultation, and patients will tell us everything that's wrong with them. And they may say, Doc, that's a ganglion cyst I have on my wrist. Can you help me with that?
Right.
And thank God we got doctors like Dr. Hochwald. We can say, well, no, I want you to go see Dr. Hochwald, who's part of our team that we consult with. I'd like to get his opinion to see what this is so we can get the best possible care for you, the patient. Now we're going to get into some very interesting things. And Dr. Hochwald, you also deal with congenital anomalies, birth defects, things like that, which I see these things, I thank God every day that, for my children being healthy.
Yeah.
But thank God there are people like you who can give these children and these people back function in their lives.
Yeah.
Let's see the first slide. And you tell us what this is. This is a child?
Right, so this falls into a broad category that we call now congenital differences, because the patients are born this way, and fortunately it's only perhaps 1 in a few thousand incidents or rate of this happening, and often there's no family history of any congenital differences, although there are a few of them that we see that have extra digits, more on the pinky side, that runs in families. But this is one of the most common, probably the most common congenital difference, where the fingers are webbed together, what we call a syndactyly. And the most common is the middle and the ring fingers, as shown in that picture in a child. We normally start out in embryo with our fingers actually webbed together, and as we develop in the placenta, we're programmed so that the fingers separate, so that the skin between the fingers separate. But for some reason, in the first trimester of growth, it's thought some changes happen that the skin that is between the fingers doesn't separate, and the most common one is this example shown.
Please skip the next slide and go to the one after that, please.
So this is another example, more extreme, of 3 fingers that are, at least 3 fingers that are syndactylized or fused together and webbed together. And more extreme examples of that happen, and what you aim to do is to try to separate the fingers so that you have independent fingers that can function. Unfortunately, there are times that they share structures, and it's hard to do that because they may share the bone. Sometimes you have to actually split the bone to do that, but most of the time it's the skin that's deficient, because if you think about it, your fingers are webbed together, you're trying to separate it, you need skin on both sides of the fingers, on each side. In the web spaces, you have to actually add skin, and we do skin grafting commonly for these.
Sometimes is there like one nerve going to both fingers, and you have to separate them, and now you only have one nerve to one finger, and the other finger is not functional?
That can be the case. I mean, if it's that extreme where the finger is not functional, then sometimes it's removed. There are cases that you can't actually get a 5-fingered hand. Right. That they're sharing so many structures that you try to get as much function out of what's there, but you're not able to get all 5 moving digits.
Right. Next slide, please. And what are we looking at here?
So this is a thumb duplication. It's extra growth of the thumb, and the thumb that is there is almost split between a normal thumb into 2 parts. Because
fingernails there, right?
There's 2 fingernails there, but if you take one of these off, the remaining thumb is often not normal either, because it's smaller, and they sometimes share also structures. So you actually have to go in and not just remove the thumb that's there or the smaller digit, but reconstruct the one that's remaining, because they can share tendons, they can share ligaments.
So you may have to move around blood vessels, tendons, to get everything back to that one thumb.
Yeah, so the remaining thumbs, to get it to function, you don't just remove the extra one, but you transfer over some of the soft tissues like the ligaments to stabilize the joint. And I think the next picture shows an x-ray of...
yeah, next slide, please.
So on the left side is the duplicate thumb. So the thumb is split into 2 bones there. And that would typically remove the outer one, the outside, because it's easier to do that, and reconstruct the remaining thumb. But like I said, that if you can see, that remaining thumb will be smaller than the normal thumb.
Next slide, please.
And this is another example of a duplicate thumb where the thumb is split off to the side. And I think we have some pictures of what we did to remove the duplicate thumb.
That's the last one. Yeah. Next slide, please.
And the sutures are in place that we put in to fix it, that absorb. The child is in a cast for about a month. There's a pin that's put in often to stabilize the remaining joints, to allow the transferred ligament to heal and the tendons to heal. And often the remaining thumb has very good function, and that's how we treat this congenital difference.
Amazing, amazing. So now I understand why, as a hand surgeon, you had to go through so much training in school, because you're a hand surgeon, you're an orthopedist, you're a vascular surgeon, you're a neurosurgeon. You're doing all these things in one operation by yourself.
Yes.
Amazing, amazing. Do you ever have any doctors assist you in any of these, or is it all just you?
So when we have a more challenging procedure, often with microsurgery involved, such as a reattachment of a finger or a hand, an amputation, it's helpful to have another surgeon experience doing that microsurgery because we work under a microscope. We have to spend hours reattaching the blood vessels because the ultimate survival of these parts that are amputated depend on trying to restore circulation going into them.
Right.
And these are very small blood vessels at the digital level that you need to fix against sutures that are smaller than our strands of hair. So having another doctor that's experienced and able to do that, because these vessels are very challenging to work on. Some of them can be the size of a pin of a pencil.
Wow.
You know, that provides circulation. And if you can't restore that, then the amputated part is going to die off.
So let me understand this. So you've got a blood vessel that might be the size of the tip of a pencil that might be cut, and you've got to reattach it together like a hose and make that blood flow through that?
Exactly.
Wow.
It's kind of like plumbing work. You have to open the channel there and reattach.
Yeah, but I understand, but that's so small.
Yes, it is. That's why it's an extra year of training that we do after a residency. We do a fellowship that starts you on that road to get experience with techniques such as that, and learning that takes time and practice.
A lot of practice.
A lot of practice, yes.
Dr. Hochwald, I want to thank you once again for being on our show. We'll definitely have you back in the future.
Thank you.
And thank you for being part of our team that we can send our patients to and get great care.
Thank you. You're welcome.
Once again, for those of you in the audience, I just want to make you, please, I hope that you understand that our team of specialists in all of our facilities, we have one thing in mind. Number one, to come up with an accurate diagnosis. Number two, to give you the best treatment possible. First and always conservative treatment to give you the best chance of getting well and crossing the bridge of health. And across that bridge, you may have to see different specialists who are part of our team to have consults with, so that everybody on your team is talking to one another, understanding what page each practitioner is on to give you, the patient, the best possible health care. Again, once again, thank you for watching The Bridge to Health. And remember one thing, if what you're looking for is real wealth, make sure you join us next time on The Bridge to Health. If you're watching us on Madhousetv, stand by. We'll be right back. If you're watching us on Cablevision, we'll see you next time.
Thanks for watching.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
If you're watching...